Dr. Gelpi joins HMU from Harvard University, where he completed a fellowship in urologic oncology. He completed his residency at Thomas Jefferson University Hospital in Philadelphia. His interests are focused on urologic oncology, endourology, robotic surgery, and clinical research outcomes. He has published in multiple peer-reviewed medical journals, presented at multiple regional and national meetings, and received many awards for his works. He is fluent in Spanish and English and is able to speak Portuguese with basic knowledge. Dr. Sachin Patil is a board-certified radiation oncologist for Houston Metro Cancer Center. He attended the University at Buffalo School of Medicine and Biomedical Sciences for his medical degree and completed his residency at the Roswell Park Cancer Institute in the Department of Radiation Oncology. In addition to his clinical expertise, Dr. Patil also has served as reviewer for the scientific journal, Journal of Applied Clinical Medical Physics. We have a lot of great content to cover tonight, so Dr. Gelpi, I'm going to turn it over to you to get us started.
Perfect. Well, thank you, Abraham. Thanks to everyone that's joining us. It's always a pleasure to have these sort of meetings where we can try and just pass along some of what we think are the highlights of what we do and why we do it. There's a lot of material that we can go through, so this is just to set up a bit of an agenda where we're going to be talking about. We always have to talk a little about the basics. So we'll talk a little about prostate cancer, we'll talk about treatment options, and then we'll get a little more into the details of why are we doing this hydrogel spacer treatment in preparation for radiation therapy. And then always great to get some questions so we can have a more engaging conversation. So without further ado, let's get into it. Prostate cancer. We always try and figure out where is this thing located. The reality is it's a very small organ that we have localized in between the space of the bladder, the rectum, and it continues with the urethra, as this one has to go right through the middle of it all. It's basically an integral part of our reproductive system. It is associated with the urinary system in the sense that it can actually, as it progresses in terms of growth, it can affect how we urinate, and we'll get into it in a minute as to the difference between what's urinary symptoms, if there's any correlation with cancer or not. But basically, it's got a very important role in providing that transfer that sperm needs when we ejaculate, and hence it's a very important part of our reproductive system during a certain part of our life. Very common question that we get asked, does enlarged prostate mean prostate cancer? Does prostate cancer means that I'm going to have urinary symptoms? And the reality is these two things tend to they can coexist, and it doesn't mean that they're one, that one is a cause for the other and vice versa. The way I like to explain it to patients, it's almost like your prostate is really two organs in one. The periphery of that organ is really the area where we tend to find cancers. The meat or the pulp of the prostate is the one that we typically associate with urinary symptoms. The reason why it's so important for men to get screened for prostate cancer is because outside of the realm of urinary symptoms, it tends to be a very silent condition. And it happens to be the most common cancer that we're seeing in men after skin cancer. The good news is it's a very curable disease. It's something that's very prevalent, and that's one of the reasons why we are so are committed to generate awareness about getting it diagnosed. But the reality is it's a condition that if you unfortunately happen to have it, we have a really good chance of getting rid of it. These are just some figures. I know that these numbers sometimes they tend to get a little confusing, but I'd say the most important message here is that it's a very common and prevalent disease. And if we wanted to summarize, about 1 in 8 men will be diagnosed with prostate cancer during their lifetime. So that means that either you or someone you know very likely has been a victim of the condition. Good thing is that as far as survival rates go, it's a very, very slow progressing condition, and hence we do have a number of alternatives to treat it and make sure that we can keep you around for as long as possible. We always get asked about what are the most common risk factors. The reality is there's a number of them. I always have to start, with age, because statistically speaking, the longer we live for, the more prevalent it's a condition. If we all happen to live till 100 years old, very likely all of us will get prostate cancer. There is a very important genetic predisposition. It does not mean that if your family members, in particular your parent, your father or your grandfather had it, you will get it. But those are patients that definitely need to be a little more aware and probably need to start their screening a little earlier. With regards to race and its ethnicity, very, very important concept to be aware of. Unfortunately, African American men as well as Hispanics, they tend to be a little more predetermined to suffer the condition, and unfortunately, because of some of our preconceptions about how we diagnose and how we treat, these are two ethnicities that typically do not seek care as much as they should. And then lastly, I always make a big point about the importance of your lifestyle, your diet, how much exercise you carry out, how much stressors in your life. All these things can indirectly also affect that potential for developing the condition. This is just a brief schematic about what are the ages that we typically recommend. Our annual meeting, we always discuss what are the recommendations, and what we typically suggest is any gentleman in the ages between 50 and 70 should get screened with both your rectal examination and a blood test that we'll get into in a minute called a prostate-specific antigen. But if you are someone that we know that you belong to a higher risk ethnicity, or if you have a very strong family history, then you should actually start that screening process earlier. What I typically do in my practice, normally when I have these gentlemen with very high risk factors, I typically get a PSA sometime around the age of 40 or so, depending on what the number looks like. I might then delay things until age 45. But again, if you're a very high risk player, then the whole process should be shifted a little earlier, and it's all in favor of protecting you. So how do we normally screen for this condition? I always make a parenthesis here, and I encourage patients to take advantage of the 3 malignancies that we have a chance to screen for. In both men and women, we can screen for colon cancer. That's what we periodically do our colonoscopies. In women, we can check for breast cancer with their mammograms. And then in men, we can check for prostate cancer with the digital rectal examination and the PSA. These are basically 3 cancers that we have the option of doing so. There's very many other malignancies that we don't have any way of looking for. So very important that you spread the word, so family members, friends, take advantage of this. The prostate-specific antigen is just a quick blood test that gives us an idea about how this protein that we can measure in your bloodstream correlates with your age, your demographics, and then we utilize to try and gauge what is the probability that you might harbor prostate cancer. By itself, it is not diagnostic, and that's a very important thing for patients to be aware of. With regards to the rectal examination, what we're looking for is trying to see if there's any nodularities, any irregularity along the surface of the prostate, because even though that will not always be the case, there's still a good chunk of patients that this is how we find that they have prostate cancer. In my experience, that typically is in the order of about every 6 diagnoses of prostate cancer, one of those men will have some sort of palpable abnormality. And then if these things are outside of the normal range, or they're abnormal, then that normally leads us to ordering other things. Sometimes we've incorporated imaging. Nowadays, we're seeing more and more the usage of MRI. We're also now getting into an era where we do have some genetic or molecular testing. And again, all these things are in an effort to try and do a biopsy when we think that it's absolutely necessary. Which brings us to a prostate biopsy being the only way that we can really confirm if there is the presence of cancer or not. We still have not been able to advance like other areas of oncology where you don't need tissue to make a diagnosis. Well, unfortunately, in prostate cancer, we'll still need to have some tissue to make that determination. When we look at malignancies, we use a very standardized way of looking at how these cancers are, and we grade them. I tell my patients that I put them in different boxes, and in order for us to do that, we're trying to incorporate a number of elements that would determine in which of those concerning boxes you end up falling into. And that's really mostly dependent on what's your PSA at presentation, what is your rectal examination. According to that, we can say if it's disease that's localized to one side, both sides, and so forth. And then we use this very important thing in our line of work, which is the Gleason score, which we'll get into in a minute. We have this system called the TNM score. T basically stands for the local extension of the tumor. We always want to know if there are lymph nodes involved in the disease, and then if there's the presence of metastasis. The good thing is that the vast majority of prostate cancers that we diagnose, we really don't have to worry too much about those last two. Typically, prostate cancer at the time of diagnosis tends to be a very localized disease. But it brings us then to this Gleason score, which in itself, it's a bit tricky, but what I like to explain patients is, all I'm trying to figure out is, do you have a prostate cancer that has the potential to be life-threatening or not? And we've come up with these sort of tools where we look at the tissue under the microscope, and we can assign a number depending on how aggressive we think that tissue has the probability of behaving like. Just for purposes of simplicity, patients that have Gleason scores of 6, we tend to put them in a very low risk category. We'll talk in a minute about what are the implications of that. And then Gleason scores are interesting because if we do the math, and I know everyone here is capable of doing that, you can have two flavors. You can have a 3+4 or a 4+3. Nowadays, we further stratified those into the lowest category being what's called a favorable intermediate risk, and that other one being an unfavorable. And then that actually has repercussions as to how we design their treatment and how much aggressive we need to be with the disease. And then anything that's a Gleason score or higher, unfortunately, falls on a higher risk category, and that again has implications in how we design the treatments. So what are our treatment options? Depending on those features that I just described, we try and put patients into a box that will be more aligned with what we think it's the aggressiveness and the probability of this cancer having an impact on the quality of life of that patient. So when you have someone that's in the lower risk categories, we can consider something as active surveillance, and I'll get into that in a minute. If, on the other hand, we feel that it's in the best interest of the patient to completely remove the prostate, then we can consider surgery, and we'll get into that in a second as well. And then lastly, we also have the opportunity to utilize a very effective way of treatment that instead of having to cut into the patient, we're just treating him from the outside, and it can accomplish the same results. A lot of this has to do, and this is part of what I tell my patients, a lot has to do with what resonates the most with them. So let's talk a minute about active surveillance. The way I like to explain this to patients is basically we know they have cancer, but the probability of that cancer being an aggressive one, it's so slim that we rather not treat them. Why? Because we know there was an era that we were over-treating prostate cancer. And as we will get into in a minute, any of these treatment options will have some side effects. Some of those side effects are minimal. Some of them are not as minimal and as well tolerated. So it's a very important thing that we have to incorporate into the discussion, that as we go through the process of figuring out what's the most appropriate way of treating that patient, these things need to be discussed. I always tell my patients when I diagnose them with prostate cancer that they have one homework, and that is they need to go home and decide if they can deal with the idea of having the cancer inside their body or they absolutely need it removed. Because if a patient is not feeling comfortable with the idea of keeping cancer inside his body, I know they're not going to be a good candidate for active surveillance. If, on the other hand, they tell me that they can feel comfortable with that, then I know immediately that they are an active surveillance patient, or if need be, they will be a good candidate for radiation therapy. We all have a different way of coming up with our active surveillance protocols, but what they basically incorporate is periodic testing in the form of that prostate-specific antigen, I do a rectal examination at least on an annual basis, and we do need to have what we call confirmatory biopsies. The way I do it, I do a biopsy, and then about 18 months down the road, I will do my next one. But some people might want to do it earlier, at 6 months, a year, and so forth. At the same time, we also try and incorporate periodic imaging, and that typically is in the form of MRI, because now we have the ability of identifying some concerning lesions with MRI technology. It's not a perfect tool, but it's a great tool to incorporate into our armamentarium. The good thing about active surveillance, there's really no side effects to it. It doesn't require any sort of anesthetics. You don't need to stay in a hospital. This is basically you coming in, getting a blood test, getting a rectal exam, and periodic biopsies as we feel that are appropriate for that patient in particular. Now, surgery, completely different beast. Surgery basically means the removal of the prostate and the seminal vesicles, which happen to be in the vicinity. And it also means that there needs to be a reconstruction of the patient's urinary tract. So the way I like to explain this to patients is, when you decide that you need surgery, or we feel that it's the most appropriate tool for your treatment, you basically are taking all your hits from the get-go. This routinely is being done in a robotic approach now in the States. I would say upwards of 95% of prostatectomies in this country are being done robotically. So that means that patients typically only stay about one night in the hospital, but they do have to deal with the recovery from a major surgery. They also need to deal with the implications of having a urethral or Foley catheter in order to help their urethra heal from the intervention. It's a very invasive procedure. We just happen to do it through very small holes nowadays. But I tell everyone that this is still a very, very important surgery. And for some people, sometimes it's a little tricky to just connect the dots between the small size of their incisions and the major surgery that they've been through. What are the typical side effects that we deal with? The first one being urinary incontinence. Most patients will recover their continence, but it's almost like they have to learn again how to contain their urine, and that typically takes some time. The one major issue that I do warn my patients about is the impact that it can definitely have in their sexual function. The most critical thing is that the quality of the patient's erections can take a hit. We do have maneuvers, treatments, things that we incorporate to try and have patients recover their erections earlier, but at the very least, they're going to have a period of 6-9 months where they're not going to have or enjoy the same erections that they had prior to surgery. And then there's every now and then we'll have a patient that later in his life, he would like to still, father a child, and it needs to be described, and this is the way that I mention it to my patients, that this is kind of like the most comprehensive vasectomy you can do in the world. Why? Because you are literally removing two of the most critical elements that you need in order to ejaculate. So with that, I'm going to handle this to my good friend, Dr. Patil, who will walk us through radiation therapy.
Thank you, Dr. Gelpi. That was a really excellent introduction and overview to the topic. Can you see the mouse cursor? Can I move the mouse cursor?
Here we go.
Can you see me moving it now?
See what, I'm sorry?
Oh, can you see me moving the mouse cursor now?
No, I can't.
So I may need your help with that.
Okay.
Can you go back one slide, Patil? Thank you. So, radiation therapy, as Dr. Gelpi had outlined, is one of the modalities in which we treat in the modern era. And it's a very effective option. But just like he had outlined with active surveillance and surgery, it's really about finding the right fit. We know that the cancer control rates in the modern era are really, really high, largely due to early detection. I'm going to come back to that point at the very end. And so if we can control the disease and we have set you up for success in terms of living out your natural lifespan, then how you live out your lifespan matters. We want you to enjoy a high quality of life. And so although that can help you kind of figure out which pathway forward is best, for those who select to move forward with radiation, these are the kind of important highlights about it. Radiation itself is just a way to get high energy into the body to help destroy the prostate gland and the cancer inside of it. And there's many ways to do that. We can deliver it with X-rays from an external source, high energy particle therapy like proton therapy, or even implant radioactive seeds or pellets into the gland. I'm going to focus really on external beam radiation because this is one of the most common ways in which its treatment is delivered in the modern era. But at the end, we'll take some questions if you have any about the other modalities. Can you advance the next slide, please? because of the geography of where we're treating and targeting, we have similar concerns in terms of potential side effects. So, you know, if you recall the first slide where Dr. Gelpi was outlining where the prostate is located and the bladder is above it and the rectum is behind it, you know, those tissues are the ones at risk for damage or irritation during surgery or even with radiation. And so when we talk about side effects, we're always going to be comparing and contrasting, but these are typically what we call the organs at risk, or as you may see, the OARs. And can we go on to the next slide? And one more. As I mentioned, brachytherapy we'll come back to at the end if there's any interest or questions, but it's just another way to get high energy x-rays into the prostate. Here they'll use either implantable seeds that will deliver radiation slowly over the course of several months, or implant needles temporarily and have high dose radiation delivered over the course of several hours over 1 or 2 implants. And then remove the needles and catheters, and you know, it's a very intensive procedure that spans maybe a day or 2, depending on what the ultimate goal is of the treatment. Next slide, please. I want to now talk about the gel spacing that's come onto the scene, because this has really changed the way radiation is delivered and really made for an even safer procedure. So for those of you unfamiliar with external beam radiation therapy, I want you to think about it in the following way. It's high energy x-rays being delivered into the body. And when we talk about external beam radiation, we really mean that it's coming from an outside source, not the pellets or the catheters I was referring to earlier. Here, what we're going to do is utilize multiple low dose or low prescription beams that come from various angles throughout the body that start to intersect as you get deeper inside. And as the beams start to converge, the energy intensifies. And where they all overlap here in the center where the prostate is, it gets very, very intense. It's almost like creating a bonfire. If you keep that image in mind, the rest is going to make a lot more sense, and so, or make perfect sense, in that, you know, starting in the center, it's very, very intense and very, very toxic, and that's really what we want. We want to destroy the prostate and the cancer inside. And as you move from the center out, the beams start to diverge. There's less overlap, less intensity, less irritation, less side effects. So with that, you know, we can now talk about the organs at risk that we're most concerned with are the bladder above the prostate, which is outlined in red, and the rectum, which is just behind the prostate here in this kind of light brown orange color, because those are the organs kind of on the periphery or the edge of the quote unquote fire. So what the gel spacer does is it actually comes in between where the prostate and the rectum are and physically occupies a space, moving the rectum back. And in doing so, it's like walking 5 or 10 feet away from, you know, the bonfire. You lower the exposure and the irritation, and thus the risk of side effects, the severity of the side effects that can develop. And so, can you move to the next slide? It's no surprise that, you know, with that, we dramatically see lowering of both GI side effects and irritation of the surrounding bladder as well, because that also can move a little bit. Next slide. Here's kind of an overview of the prostate and the rectum. Without the gel spacer, you can see that the rectum would be right there on the edge of the prostate, and in this kind of pink zone here, where it's being exposed to a lot of the high energy and high intensity of the radiation. But now, because of the gel spacer physically bumping it back, it's outside of that zone. It will still see some radiation, and there's still some risk of side effects, but it's very mild and minimal compared to what it would have otherwise seen, being front and center. That distance that the gel spacer creates is about 1/2 inch, which is about the length of your pinky nail from top to bottom. It doesn't seem like a big distance, but for scales of distance related to radiation, it's a huge advantage to move it even that far back. And so in general, with just a very quick 15-20 minute procedure, the gel spacer can be placed in that physical space between the prostate and the rectum, move the rectum back, dramatically lower its exposure, and thereby dramatically lower potential short-term and long-term side effects. It's an easy implant to place, and the gel will stay in for about 3 months and then start to resorb, breaking down into its constituent parts, mainly water and some ethylene glycol, which will pass through the urine and the stool respectively. Can we go to the next slide, please? So again, because of the way it changes the geometry and the geography of these organs that are really close to the prostate, you lower the exposure and the risk, and so it's no surprise that side effects also improve. Next slide, please. So this kind of summarizes, a lot of the points Dr. Gelpi and I have been building up towards, which is that radiation can be a very effective treatment option. There are always potential side effects with any sort of intervention that you do, but this is a way to help make the procedure even safer. It's extremely well tolerated, very fast, and really setting the standard in the modern era of how treatment should be delivered. Next slide, please. So again, a lot of the key parts to really think about for this discussion is that the big take-home message is that screening saves lives. Dr. Gelpi had mentioned that the cancer control rates and the cure rates nowadays are upwards of 95, 98%. And really all of that has to do with the fact that people are being found much, much earlier in the process. So when you catch problems early, they don't really have a chance to get out of hand. And screening does save lives. Back before the advent of the PSA test, the survival rate for prostate cancer was in the single digits, close to 4 or 5%. And it may sound shocking nowadays because almost everyone survives it, but that's because by the time you develop symptoms, it was too late. It's like mold on the walls, but by the time you can smell it or see a little bit, on the surface of the wall, it had already spread everywhere. So you cut through the sheetrock, and then you see through the insulation. I mean, it's all throughout, and that's a much harder problem to contain, let alone control long term or cure. But because of screening and the PSA test, we're often finding disease so early that almost anything you do can really provide long-lasting disease control. And so, how you choose among the various options like surgery, radiation, or even just monitoring, that ends up being a personal choice, and it's a good discussion to have with your doctors, given your personal medical history and the context of that. But it really all boils down to screening. And because patients are coming in so early, we are focusing a lot of the talk on maintaining quality of life. And so, we know you're going to do well long-term from the disease standpoint. Hopefully you've now gotten a little bit more information about how we can work in the modern era to really protect those quality of life issues as you enjoy your living out your natural lifespan. So with that, I'll turn it back over to Drs. Gelpi and Abraham.
All right.